Good afternoon, everyone. My name is Kristen Rigo, and I'm with the Community Health and Prevention team here at the Association of State and Territorial Health Officials. I would like to welcome you to today's webinar, Supporting the 2015-2020 Dietary Guidelines for Americans, the Role of State and Territorial Health Agencies. ASTO, with support from the Office of Disease Prevention and Health Promotion, is working on this exciting project to assess the current uses of the Dietary Guidelines for Americans and to educate and mobilize state health leadership to utilize and integrate the guidelines throughout agency programming. ASTO has captured state stories, is developing an issue brief, and is working to identify other resources to support the implementation of the guidelines, which will all be available on ASTO's website. In addition, today's webinar will be archived and posted on our website in the next couple of days. The objectives for today's webinar are to provide an overview of the key recommendations from the 2015-2020 Dietary Guidelines for Americans, provide examples of how state health agencies can lead or support effective strategies to increase healthy eating across various sectors and settings in their state. We have an esteemed panel of experts that will be speaking with you today. Following my introductions, all of the speakers will present their slides. If you have a question, you are welcome to post it in the chat box on your screen at any time during the webinar. These questions will be used during the Q&A after today's presentation. At the conclusion of the webinar, you will be directed to an evaluation survey. Please take a few minutes to inform us about the work you are doing to increase healthy eating in your state and provide us with feedback on today's webinar. We look forward to hearing about your efforts. Now I'd like to introduce today's speakers. Dr. Kelly Casavell is a nutrition advisor in the Division of Prevention Science at HHS's Office of Disease Prevention and Health Promotion, where she has worked since October of 2012. Dr. Casavell supported HHS in its leadership of the development of the 2015-2020 Dietary Guidelines for Americans policy documents, supporting both the federal process and content development. She was one of 4 co-executive secretaries who led the process for the 2015 Dietary Guidelines Advisory Committee. In addition, she was a member of the policy document writing staff for the Dietary Guidelines for Americans 2010. Previously, she was employed for 7 years at USDA's Center for Nutrition Policy and Promotion, where she was part of the core team that supported the 2010 Advisory Committee and managed the process for updating the Dietary Guidelines for Americans, and served on the Healthy Eating Index research team led by USDA. Dr. Monica Burrell became Commissioner of the Massachusetts Department of Public Health in February of 2015. As Commissioner, she is responsible for spearheading the state's response to the opioid crisis, as well as leading the department's implementation of healthcare cost containment legislation, Chapter 224, reducing health disparities, finding public health solutions for healthcare reform, finding innovative solutions using data and evidence-based practices, and other healthcare quality improvement initiatives. Dr. Burrell is widely recognized for her dedication to healthcare for underserved and vulnerable populations. She previously served as the Chief Medical Officer of Boston Healthcare for the Homeless Program, the largest nonprofit healthcare organization for homeless individuals in the country. Patricia Simmons has worked as a registered dietitian for over 15 years and currently is the Chief of the Bureau of Community Health and Wellness with the Missouri Department of Health and Senior Services. Through her work at the department, Ms. Simmons has been active in statewide obesity prevention efforts, including the Missouri Council for Activity and Nutrition, Worksite Wellness Initiatives, and the Missouri Eat Smart Guidelines for Child Care. She spearheaded the planning, development, and implementation of more than 7 obesity prevention strategies related to making policy and environmental changes, as well as provides technical assistance to stakeholders on program implementation. As was mentioned earlier, if you have a question during this call, you are welcome to post it in the chat box on your screen at any time. These questions will be answered during the Q&A at the end of today's presentation. We will also open up the phone lines during the Q&A session for you to ask additional questions. And with that, I'll now turn it over to Kelly.
Great. Thank you, Kristen, and thank you everybody who's on this call today. As public health professionals, we recognize that everyone on this call today really does share a vested interest with us in protecting the health of all Americans. And collective action is needed to create a new paradigm in which healthy lifestyle choices at home, at school, at work, and in our communities are really easy, accessible, affordable, and become the norm. So I'm really happy to be here today to tell you about the 2015-2020 Dietary Guidelines for Americans that were released earlier this year, what's new about them, and what free resources are available to you to update your programs, expand them, and start new initiatives as well. So first, creating each edition of the Dietary Guidelines is a joint effort of HHS and USDA. The Dietary Guidelines are required by law to ensure that advancements in scientific understanding about the role of nutrition and health are incorporated every 5 years. Now, the process has become increasingly robust and transparent. The main purpose of the guidelines is to inform the development of federal food, nutrition, and health policies and programs. And so the primary audience of the policy document itself is policymakers, as well as nutrition and health professionals. However, the policy's language is not designed for consumers directly, and the focus of our policy document is on disease prevention rather than disease treatment. Now, the process to develop the dietary guidelines includes 3 stages. In the first stage, there's an external Dietary Guidelines Advisory Committee that provides advice to the federal government on the current state of the scientific evidence on nutrition and health. The 2015 Advisory Committee used 4 state-of-the-art approaches to review and analyze the available evidence and submitted its scientific report to the secretaries at HHS and of USDA. In the second stage, HHS and USDA then developed the policy, applying several process steps to promote scientific rigor. Extensive review and clearance of the policy document occurs within both departments, which culminates with the review and approval by both secretaries, the Secretary of HHS and the Secretary of USDA. Now, in the third and final stage, which is where we are now, the federal government implements the recommendations. And as will be demonstrated today, there are ample opportunities where many other sectors can implement the dietary guidelines in the multiple settings that you influence. The guidelines serve as the evidence-based foundation for federal nutrition education materials, which are required by law to be consistent with the dietary guidelines. It's also used to inform USDA and HHS food programs, and those of other departments as well that are listed here. Now, of course, it also impacts non-federal public health initiatives and activities across the nation. And the work of the state and territorial health officials plays a very important role. We know so many of you have implemented the guidelines of previous editions, and we really do appreciate those efforts and look forward to future opportunities with this edition as well. Since the guidelines just came out in January, you haven't had time yet to update your initiative. So hopefully the information that I described today will help you streamline and accelerate those efforts. So what will you find in this edition? Well, first, people do not eat foods and nutrients in isolation, but in combination, and that forms an overall eating pattern. There's a growing body of research that has examined the relationship between overall eating patterns, health, and risk of chronic disease. And you'll find that eating patterns and their food and nutrient characteristics are a primary emphasis of the recommendations in this edition. This edition has an executive summary, followed by an introduction, 3 primary chapters, and then 14 incredibly informative appendices. This edition of the Dietary Guidelines looks at healthy eating patterns from 3 vantage points. First, in Chapter 1, we examine what they are, with examples that are adaptable to personal tastes, traditions, and budgets. Then in Chapter 2, based on current intake data, we explore shifts that are needed to more closely align with healthy eating patterns. And then last, in Chapter 3, we provide a call to action across sectors to support healthy eating patterns in the United States. The 2015-2020 Dietary Guidelines is built around 5 overarching guidelines with supporting key recommendations. So what are the guidelines? Well, first, follow a healthy eating pattern across the lifespan. All food and beverage choices matter. Choose a healthy eating pattern at an appropriate calorie level to help achieve and maintain a healthy body weight, support nutrient adequacy, and reduce the risk of chronic disease. Focus on variety, nutrient density, and amount. To meet nutrient needs within calorie limits, choose a variety of nutrient-dense foods across and within all food groups in recommended amounts. Third, limit calories from added sugars and saturated fats and reduce sodium intake. Consume an eating pattern low in added sugars, saturated fats, and sodium. Cut back on foods and beverages higher in these components to amounts that fit within healthy eating patterns. Fourth, shift to healthier food and beverage choices. Choose nutrient-dense foods and beverages across and within all food groups in place of less healthy choices. Consider cultural and personal preferences to make these shifts easier to accomplish and to maintain. And last, support healthy eating patterns for all. Everyone has a role in helping to create and support healthy eating patterns in multiple settings nationwide, from home to school to work to communities. Now, these 5 overarching guidelines are supplemented with a number of key recommendations that provide more specific guidance on healthy eating patterns. The key recommendations should be applied in their entirety. The first recommendation is to consume a healthy eating pattern that accounts for all foods and beverages and within an appropriate calorie level. A healthy eating pattern includes a variety of vegetables from all of the subgroups, fruits, especially whole fruits, grains, at least half of which are whole grains, fat-free or low-fat dairy, including milk, yogurt, cheese, and or fortified soy beverages, a variety of protein foods, including seafood, lean meats and poultry, eggs, legumes, and nuts, seeds, and soy products. Oils such as canola, corn, sunflower, etc., as well as oils that are naturally present in foods like nuts, seafood, and avocados. And the key recommendations also note that healthy eating patterns limit saturated fats and trans fats, added sugars, and sodium. There are also quantitative key recommendations that are components of particular public health concerns. One of the new recommendations is a quantitative recommendation to consume less than 10% of calories per day from added sugars. The added sugars recommendation is considered a target. It's based on food pattern modeling and on national data on intakes of calories from added sugars. This target demonstrates the public health need to limit calories from added sugars to meet food group and nutrient needs within calorie limits. Also, consume less than 10% of calories from saturated fats. This recommendation is also a target. However, it is based on evidence that replacing saturated fats with unsaturated fats is associated with reduced risk of cardiovascular disease. It's important to note that replacing saturated fats with carbohydrates is not associated with reduced risk of cardiovascular disease. Also, for most calorie levels, there are not enough calories available after meeting food group needs to both consume 10% of calories from added sugars and 10% of calories from saturated fats while still staying within the calorie limit. Now, the sodium key recommendation has been refined. Americans are encouraged to follow the tolerable upper intake levels, or ULs, that are set by the Institute of Medicine. The UL is 2,300 milligrams per day for ages 14 years and older, and the recommendations for children younger than 14 years vary from 1,500 to 2,200. The text of Chapter 1 of the Dietary Guidelines also describes that for adults with hypertension or prehypertension, further reduction to 1,500 milligrams per day can result in greater blood pressure reduction. Now, the alcohol limit has not changed. However, no health benefits of alcohol are discussed in the policy document, and additional information is provided in Appendix 9 on variation in alcohol and calorie content by portion size. Now, lastly, Americans of all ages should meet the physical activity guidelines for Americans to help promote health and reduce the risk of chronic disease. The dietary guidelines provide 3 examples of healthy eating patterns. All 3 were designed to consider the types and proportions of foods Americans typically consume, but in nutrient-dense forms in appropriate amounts, attainable and relevant in the U.S. population. The healthy U.S. style pattern is most identical to the base pattern of the 2010 Dietary Guidelines. The healthy Mediterranean style pattern is new to the guidelines. In addition, the vegetarian pattern has been updated using actual data on what vegetarians consume in the United States. In addition to the food groups, it's important to consider other food components when making food and beverage choices. The components discussed in this edition include added sugars, saturated fats, trans fats, dietary cholesterol, sodium, alcohol, and caffeine. These are examples of the types of information provided with the examples of dietary cholesterol and caffeine. Now, for cholesterol, the previous key recommendation to limit dietary cholesterol to 300 milligrams per day is not in the 2015 edition. But this change does not suggest that dietary cholesterol is no longer important to consider when building healthy eating patterns. As recommended by the Institute of Medicine, individuals should eat as little dietary cholesterol as possible while consuming healthy eating patterns. For example, the healthy U.S.-style eating pattern described in the guidelines contains about 100 to 300 milligrams of dietary cholesterol across 12 calorie levels. Now, caffeine is a new topic to this edition of the Dietary Guidelines. Much of the available evidence on caffeine focuses on coffee intake. 3 to 5 8-ounce cups per day can be incorporated into healthy eating patterns. However, individuals who do not consume caffeinated beverages should not start. You must also consider other calories that come along with many caffeinated beverages, and these calories should be limited. A specific recommendation for energy drinks is not provided because the current evidence on energy drinks and chronic disease is limited. Chapter 2 describes that typical eating patterns do not align with the dietary guidelines. This figure, figure 2.1 from the guidelines, provides a snapshot. The center line is the goal or limit. The bars represent the percent of the U.S. population ages 1 year and older who are below, at, or above each dietary goal or limit. In short, the orange bars represent the percent of Americans who are not meeting recommendations and show areas that have room for improvement. So this is why collective action to positively impact eating patterns in the U.S. are so essential and the focus of today. For each food group and other component, Chapter 2 of the guidelines identifies suggested shifts that Americans can make in their food and beverage choices to move intakes closer to the recommendations and limits. And this slide shows just a few examples of the shifts that are suggested. Now, a multitude of factors affect the food and physical activity choices an individual makes, and these decisions are rarely made in isolation. Sectors and settings, as well as individual factors and social and cultural norms and values play a role, which ultimately influence health outcomes. Consistent evidence shows that implementing multiple changes at various levels of the socio-ecological model is effective in improving eating and physical activity behaviors. Among the components of the socio-ecological model, sectors and settings influence the change at the population level, and interventions at these levels may have a broader public health impact. Now, sectors include systems such as government, education, healthcare, and transportation, organizations such as public health, community, and advocacy organizations, businesses and industries such as those in planning and development, agriculture, food and beverage, retail, entertainment, marketing, media. These sectors all have an important role because they either influence the degree to which people have access to food and or opportunities to be physically active, or they influence social norms and values. Positive influences on social norms and values can occur through health promotion and marketing strategies, which ensure the proper exchange in messaging and diffusion throughout the community. So if you are a professional with influence at the sector level, I encourage you to look for opportunities to identify and develop strategies that help individuals align their choices with the dietary guidelines. Strategies could include supporting policy and or program changes, fostering coalitions and networks, developing or modifying products and menus, or creating opportunities to be physically active. Now, for settings, individuals also make choices in a variety of settings, both at home and away from home. And these organizational settings determine what foods are offered and what opportunities are there for physical activity. Strategies to align with the guidelines that are implemented in these settings can influence individual choices and have the potential for broader population-level impact if they are integrated with strategies by multiple sectors. For social and cultural norms and values, because norms and values are prevalent within a community or setting, changing them can be difficult. However, changes to sectors and settings can have a powerful effect on social and cultural norms and values over time. And lastly, the individual. Eating patterns tailored to the individual are more likely to be motivating, accepted, and maintained over time, thereby having the potential to lead to meaningful shifts in dietary intake and consequently improved health. The guidelines encourage looking across the socio-ecological model to identify strategies for successful change. And actions must involve a broad range of sectors, occur across a variety of settings, and address the needs of individuals, families, and communities. The example shown here is for schools. But at home, individuals and families can try out small changes to find out what works for them, like planning meals and cooking at home. Workplaces can offer healthy food options and food service operations, vending machines, and at staff meetings or functions. They can implement worksite wellness programs with options for nutrition counseling and can encourage walking meetings and active breaks. Communities can create walkable communities by maintaining safe public spaces and support ways for all members of the community to access healthy food, either through community gardens, farmers markets, food banks, etc. Food retail outlets can inform consumers about making healthy changes and also, of course, provide healthy food choices. So as I wrap up today, I want you to know that SHS has recently released a suite of additional professional materials. These include handouts on added sugars and healthy eating patterns, tips and conversation starters, sample social media messages and posts, infographics, and even a presentation slide deck that's complete with notes and commentary. We are also updating our Eat Healthy Be Active community workshop series. All of our products are in the public domain and free for you to use and or adapt. So please also sign up for our Dietary Guidelines listserv at dietaryguidelines.gov for monthly updates, as new free resources will become available in the future as well. Now with that, I'm going to turn the floor over to Dr. Monica Burrell from Massachusetts Department of Public Health. Dr. Burrell?
Thank you so much, Kelly, and good afternoon, everyone. It's a pleasure to be here with you to talk about a little bit of the work that we're doing here in Massachusetts. After Kelly gave us that excellent overview of the new dietary guidelines for Americans, I'd like to take a few minutes to talk to you about how we in Massachusetts are envisioning making healthy choices easier for those of us here. So I'd like to start by framing the work that we're all talking about here in our overall DPH goals and priorities, so we can see how the current work fits in very nicely with our overarching values. This is my Massachusetts DPH house, if you will, and you'll see our vision and mission listed up above, similar to many of yours, I'm sure, to prevent illness, injury, and premature death, and to ensure access to high-quality public health and healthcare services, and promote wellness and health equity for all people. That work is driven by several drivers, including a laser-sharp focus on using data effectively, addressing the social determinants of health, and a firm commitment to eliminating health disparities. And we do this work on a foundation of everyday excellence, using continuous improvement and performance management, passion and innovation to solve the complex issues of public health today, and with inclusiveness and collaboration. So looking at our goal of being outcomes-focused public health practitioners using data-driven approaches and a focus on quality health and healthcare services with the goal of an eradication of healthcare disparities, I want to focus us now just for a minute on some of the data. So here's a slide that many of you may have seen looking at the increasing rates of obesity across the U.S. And here is some information from Massachusetts, where we noted that from 1990 to 2007, we saw the prevalence of overweight and obese adults increase by 47%. And in our most recent data, as we break the data down further, we see that this runs along income levels, and you'll see the green line is the lower income group with higher rates of childhood obesity. And looking at these same numbers along race and ethnicity, you'll see that the highest levels of obesity are seen in Black, non-Hispanic in our population. So now I want to talk to you a little bit about some of our work that we're doing with Mass in Motion. So Mass in Motion is a program that we have here about eating better and moving more. And it's a multifaceted program that was launched in January of 2009 to promote wellness and to prevent overweight and obesity in Massachusetts. The purpose of this campaign is to promote the importance of healthy eating and active living at home, at work, and in communities throughout Massachusetts. The goals of Mass in Motion continue to be decrease the number and percent of both adults and children who are overweight and obese, and decrease the prevalence of chronic disease associated with these unhealthy eating and lack of physical activity. And these goals are accomplished by making the promotion of wellness and prevention of overweight and obesity a top public health priority, and creating conditions that encourage, nurture, and promote wellness. The components of this program include a call to action report, regulatory and policy changes, collaboration across state agencies, public information campaigns, healthy community initiatives, and leadership programs. You can find more about this program, Mass in Motion, at our website, mass.gov/massinmotion. So today, I'd like to focus on the regulatory and policy change portion of Mass in Motion as we talk about our topics today. So I'll spend most of my time today on our state food procurement standards, or Executive Order 509, but want to briefly discuss two other areas as well, BMI reporting and our school nutrition standards. We had regulations passed by our Public Health Council in April of 2009, and again, those were amended in October of 2013. And these regulations require BMI testing for all students in grades 1, 4, 7, and 10. Schools are required to report the data to the Massachusetts Department of Public Health in aggregate. And this provides us with a tremendous amount of surveillance data, some of which I just shared with you, to the department that we did not have before, and it gives us information on where to target, strengthen, and evaluate initiatives that are successfully reducing incidence of childhood obesity. The changes made in October 2013 eliminated the requirement for a letter to be sent home to all patients about BMI testing, but the reporting mandate continued. In the school nutrition standards, the Act relative to school nutrition was signed into law in July 2010 and required the Massachusetts Department of Health to establish standards for competitive foods and beverages sold or provided in public schools during the school day. The standards apply to foods and beverages sold or provided in school cafeterias as a so-called a la carte item, vending machines, and school stores and snack bars. The Department of Public Health worked closely with the Massachusetts Department of Elementary and Secondary Education to develop guidance to support school districts as they implemented these standards. The regulations were approved by Public Health Council in June 2011 and were then updated in 2014 to align with USDA standards. And we do remain more strict than the USDA in several areas, and some examples of these include no exemptions to the a la carte entree items, restrictions on caffeine and artificial sweeteners, and keeping beverages at 8 ounces for all grades, and finally keeping 22 grams of sugar limit to any flavored milk. Now I'd like to spend the rest of my time to focus on our state food procurement, or Executive Order 509. This executive order was signed into law in 2009 and is the first in the nation's state food procurement standards requiring that our state agencies follow nutritional standards when buying or serving food and beverages. The standards apply to contracts procured on or after July 1st, 2009. There are 9 impacted agencies and that provide a package of services which includes food and beverages to clients who are dependent on the state. Examples include our Department of Youth Services, our Department of Disability Services, our Department of Public Health Hospitals, our Departments of Corrections, and the Department of Mental Health. There are an estimated 141 million meals and snacks per year. The standards do not apply to vending, concession, or cafeteria food, just non-impacted state agencies. There's 68, but that they're not impacted by this, but they are encouraged to use the Healthy Meeting and Events Guide. I'm not going to read the full executive order, but I do want to highlight a couple of sections. Whereas state government can promote healthier eating habits and serve as a model for businesses, institutions, and residents by requiring that all state contracts for the purchase of food or the provision of food services adhere to defined nutrition standards. So as a state, we procure a lot of food, and this is an important step for us to quote-unquote walk the walk. If we want others to offer healthy food, this is a way for us to do it as well. And second, whereas the Commonwealth's adherence to nutrition standards will encourage food suppliers and service providers to incorporate such standards into their products and operations generally. So procurements can be a powerful tool in creating healthier options as the industry creates or changes their products to meet these standards. Each state agency shall ensure that it purchases and provides food that meets defined nutrition standards. And towards that end, beginning with all contracts procured after July 2009, state agencies that purchase or serve food shall comply with nutritional standards established by the Department of Public Health. These guidelines will govern the purchase and serving of food by state agencies and shall ensure that persons served by such agencies are offered a broad choice of healthy, balanced meals and snacks. The department may phase in the guidelines to accommodate existing contracts and to provide gradual modification of prevailing food preferences. I highlight this piece for a couple of reasons. First, it reinforces that each impacted agency shall ensure that it provides foods that meets the defined nutrition guidelines established by the Department of Public Health. And second, it does not include language regarding oversight or enforcement. It states agencies must follow our guidance, but does not give us any formal role in monitoring compliance. Most of the work to date has been with agencies that have been willing to come to the table and work with us and want to promote this among their agencies. The Massachusetts Department of Public Health worked closely with an interagency advisory board, which included representatives from each of the impacted agencies, to develop these standards. And the standards encourage use of healthy food options, such as increasing whole grains, increasing fruits and vegetables, using lean meats and alternative protein sources, and using skim or non-fat dairy products, a lot of what you heard in the first presentation. And the standards were revised in 2012 to align with the 2010 DGAs and will be reviewed for possible updates to align with the 2015 DGAs that you just heard about. DPH contracted with an academic partner, the Framingham State University, to develop an online training in these nutritional standards. The Food for Health course is supported through federal chronic disease funds and promoted to each impacted agency. Food service personnel at each impacted agency enroll in the course and complete the 5 one-hour modules. And then additional guidance materials are available, including fact sheets on increasing whole grains, increasing fruits and vegetables, and so on. The interagency work group has also created the Healthy Meeting and Event Guide that can be used by all state agencies to ensure that all meetings are so-called healthy meetings. So another way for us to intervene in the state agencies that weren't necessarily involved in this executive order. Just to give you some of the evaluation data, so at baseline, 63% of respondents were following some kind of nutritional standards before the executive order, but only 33% were following even half of what ultimately became our nutritional standards. Our follow-up survey showed that there was a significant increase, with 58% reporting always or most of the time following our standards, and awareness had increased to as high as 77%. Again, the advisory board continued to meet quarterly through 2015 and provided feedback that some agencies have employees who would benefit from training but didn't have reliable computer access. So to address that, the department worked with the Framingham State University to modify the training so that we could also have an in-person delivery. So the in-person trainings are available to agency personnel as well. So again, trying to accommodate the needs of the agencies so that they're able to fulfill the requirements. And finally, just to talk a little bit about, as you think yourself of potentially using this as a model for the executive order, just to talk a little bit about some of the challenges and opportunities. There are no dedicated funds to support implementation of the executive order, but the department, we have been able to leverage federal chronic disease funds since the work is so aligned with those grant deliverables. So we have been creatively able to have the funding, but did not specifically have dedicated funds to that implementation process. And the executive order requires that state agencies follow the nutritional standards for purchasing and preparing food to clients, but did not include language around measuring compliance. So really there's no enforcement, but the department continues to support implementation resources and training to make sure that we can help our sister agencies comply with this executive order. The recent release of the 2015 Dietary Guidelines for America will offer the opportunity to bring our stakeholders together to review the existing Massachusetts nutrition standards and update them as necessary. So with that introductory comments, I will now pass it on to Pat. Thank you very much.
Good afternoon, everybody, and I would like to start by thanking you for the opportunity to talk about one of Missouri's strategies to increase access to healthy foods so that people have the ability to obtain diets that follow the dietary guidelines and have foods that contribute to a healthy eating pattern. The intervention doesn't have specific nutrition criteria, such as in with the last speaker, but rather we use the dietary guidelines to guide our definition of healthy foods. And I'd like to thank Kara Lubisher from University of Missouri Extension for allowing me to use slides that she has previously developed. Stock Healthy, Shop Healthy is an evidence-based initiative that we launched in 2014 that assists communities working to improve access to healthy foods by working with small food retailers. Our communities are working with a variety of different retailers, from rural grocery stores to convenience stores and corner shops. The initiative is part of our CDC 1305 chronic disease grant work plan. But our partnership with the University of Missouri Extension to work on healthy food retail started well before the CDC grant. The funding cycle really gave us the opportunity, though, to formalize the intervention and have more intentional work with local communities in terms of getting it implemented. The model was developed by University of Missouri Extension through their St. Louis Healthy Corner Store initiative. It utilizes a unique approach that involves engaging small food retailers and the community to address supply and demand at the same time. It really is a community-driven model that empowers local communities to create change. Stock Healthy, Shop Healthy wouldn't be successful without the partnerships between Extension, the State Health Department, and our local health agencies. The University of Missouri Extension serves as our lead agency and provides program planning and support, and also resource development. They provide a one-day training for all of the communities that are participating at the start, and then provide ongoing technical assistance through monthly calls and site visits. They also have local program support through community development specialists and nutrition specialists. And then they also provide evaluation support and assist our local agencies with data collection and summarizing the data. Our role as the State Health Department is really to convene and to connect the partners, especially the local public health agencies, and to serve in an advisory role. We recruit potential communities and provide funding for local implementation, and also for Extension to provide training and TA to the local communities. We're currently in our second year of implementation, and the LPA, our local health agencies, are implementing the intervention. They select stores that they work with. They're tasked with building a community network and then working with store owners to make changes. And with the changes in SNAP-Ed allowing policy systems and environmental change work, we're also able to expand and have local extension specialists lead efforts in local areas as well. And so the intervention was recently added to the approved toolkit for policy system and environmental change for SNAP-Ed. So the overall goal of the program is to increase access, but we don't just address availability of food, but consider all of the following in thinking about access. So is there transportation? Can residents walk, bike, or is it within a reasonable car ride to the food source? What is available? We work with many rural grocery stores, and so they often do have fresh fruits and vegetables, for example, but how much variety is there, and what is the quality? Is the food affordable? And also, if someone can get their hands on it and they can afford to buy it, do they know how to prepare it in a healthy manner? So we try to address all of these issues through Stock Healthy, Shop Healthy. Small food retailers are an important venue for this work because they have many roles within their community beyond food access, such as being an employer, and especially in rural communities, they're often a strong community partner and often critical to sustainability of a small town. One of the more important reasons we decided to focus on this retail venue is because they provide a year-round solution to closing the food gap, whereas community gardens and farmers markets are generally seasonal solutions. They're also open a substantial number of hours most days of the week. This diagram shows the different pieces of the Stock Healthy, Shop Healthy model, and as you can see, there's a large emphasis on building demand for healthy foods. It's really a delicate balance between increasing access to healthy food and building the demand in the community. We don't want to increase the supply if there's no customers to buy the food items, because then the retailer is going to get frustrated and lose interest in the program. It really puts their investment at risk. So changes made to the stock have to be paced with outreach and promotion activities. Extension helps each of our communities to work through each step of the process, and really collaboration is critical for the success. And so partnership is usually the first task when we start a new community. In fact, we discourage local agencies from engaging with the store if their community network isn't developed. Some of the key activities around building demand are inviting other organizations to the table, and that just helps to create awareness of the program within the community. Also building a partnership with the store owner, and so just beyond meeting with them once or twice, but really developing a relationship. They also host nutrition education classes with local extension nutrition specialists and hold a lot of community outreach activities, such as collecting customer feedback through surveys. They do the top picture is a poster board survey, and this is one of the more popular and effective activities where the poster board is put up in the store and allow customers just to write on. It's very simple, but they just write on what they would like to have available in the store. And then they do a lot of marketing and promotion of the store, holding taste test events and kickoff events and other type of in-store promotion. One of the other things that they also encourage is the use of a loyalty card. So if you buy 10 pieces of produce, you get the 11th free, for example. And some of the activities done to increase supply include collaborating with community partners to identify what shoppers want or are willing to purchase. They also improve store layout and merchandising, so maybe moving the fruits and vegetables up closer to the front of the store or having a fruit stand by the cashier. Stores also, they strive to add healthier foods, but we try not to encourage, it's not always about adding fresh produce, for example, because that can be a pretty risky addition. And so starting, maybe it's just having whole grains or maybe adding some canned fruits or vegetables as a starting point, and then working from there as they continue to build demand. And then also looking at the store appearance to make it more inviting to the community. For example, one of our stores replaced 2 large alcohol advertisements at the store entrance with posters showcasing the new healthier items that are sold inside. Extension has really done a fantastic job with developing tools and resources for local communities wanting to learn more about healthy food retail or even implementing a program. All of the materials are housed on and available on the website and are available to download at no cost. The resources include separate toolkits for retailers and community members. The community toolkit includes strategies for identifying stakeholders and forming a network, developing partnerships with the store, and also talks about some key building demand activities. And the retailer toolkit includes strategies for partnering with a network or stakeholders and key supply increasing activities. The website also houses the evaluation toolkit and a webinar series on healthy food retail. And this past year, we also added Spanish materials. This is just shows where Stock Healthy, Shop Healthy is being implemented in Missouri. There are currently 22 stores. As I mentioned, we're in our 2nd year of implementation. And so we have 22 stores that are evenly spread between urban and rural locations. And we're currently in the process of recruiting for our year 3 communities. So I wanted to talk just a little bit about evaluation. Stock Healthy, Shop Healthy has both quantitative and qualitative evaluation components. The qualitative includes interviewing community members and store owners and gathering customer feedback. And Extension adapted a healthy food shelf space measurement tool and an environmental audit, which are required for our participating communities. the Healthy Food Shelf Space Measurement Tool is a proxy measure for sales data because sometimes that information isn't always available depending on the retailer. And so you can see here in year one, we showed an 8.7% increase in shelf space dedicated to healthy goods. Communities are also, so they're encouraged to collect sales data and to track the number of loyalty cards in addition to collecting surveys of the community and store customers. The education activities that they conduct also have an evaluation component. So here's some additional results. These numbers represent year one and then through midpoint for year two implementation. So as I mentioned, we have 22 stores split pretty evenly between urban and rural areas. 37 nutrition classes have been offered, which range from like one-off class events to programs that are curricula that have multiple sessions, and also some in-store education events. 40 store changes have been made, such as updating displays, adding new basket stands or shelves, painting new coolers, or moving produce coolers to the front of the store. 32 community outreach and engagement activities have been conducted, and these activities include partnering with a local church to host a wellness fair, community surveying, doing press releases and media about participation in the program. And one of our communities also partnered with their local 4-H and held a smoothie competition, which is really creative and involved a lot of their partners. The store donated the ingredients for the smoothie for the youth to make the smoothie. It's really successful. And 27 community partners have been engaged. Examples include hospitals, churches, schools, community-wide health coalitions, Chamber of Commerce, and neighborhood associations. And just over 300,000 is the potential population reach looking at zip code data. So I wanted some other results are just from survey or interviews. The retailers reported an increase in demand for healthy foods due to in-store nutrition education and the point of decision prompts, or what we call shelf talkers. And the community partners really felt that their activities were effective in increasing awareness of the retailers and the changes that were made. One of the issues is that community members have a perceived notion of what the store was like. So one of the biggest hurdles is to how can they let people know that there's healthy foods now available in the store. So I wanted to end by talking about a few of our challenges or lessons learned. The first is that strong partnerships are a must. The communities that had existing partnerships in place, or at least some type of relationship with local organizations, seem to have better results. And again, just encouraging that they not start working with the retailer until their partnership is built. However, this can be a slow process. True community development can be slow, and so sometimes they had to kind of be patient and help the local agency understand that, you know, this is a really key piece, especially thinking about sustainability. We have to be sensitive to who's delivering the message. So as I mentioned, the local public health agency is often the lead agency, but they might not be the best person to approach the store owner. And so really looking at the strengths of the community and who's in the community network. In some cases, the health agency regulates the store, and so there might be a different kind of relationship there. And then finally, looking at becoming a SNAP eligible is really encouraged. It wasn't a requirement, or it's not a requirement for our program, but really do encourage it because it helps to build sustainability and build the customer base. And so that's Kara's information and my information if you have any questions, and also the website where you can find the materials for Stock Healthy, Shop Healthy.
Great. Thank you so much, Kelly, Monica, and Pat, for your very informative and engaging presentations. We have a few minutes left, so we're going to open up the Q&A session. If you would like to ask a question, please type it into the chat box located on your screen. We will also ask the operator to provide instructions for how to unmute your line if you'd like to ask a question verbally. Operator?
If you would like to register a question, please press star followed by the number 1 on your telephone keypad. If you'd like to withdraw your question, press the pound key.
Great, thanks. And so while we're waiting for any questions to come in over the phone line, we did have a few questions that were posed during today's presentations. And the first one's for Dr. Burrell. Can you, I think you might have done this quickly, but can you list off again the departments that are involved in Executive Order 509?
Yes, hello. I did list some of them, and in the interest of time, I cut that short. So as I was explaining when I was speaking about it, it doesn't apply. We have 9 impacted agencies, and those are the ones that provide a package of services including food and beverages, and that's DDS, DYS, DCS, DPH hospitals, DMH, DOC, Sheriff's Office, Executive Office of Elder Affairs, Veterans Services. There are 68 other agencies that are not impacted because of the nature of the order, but they are encouraged again to be at the table and to use the Healthy Meeting and Event Guide.
Great, thank you so much. And then the next question is for Pat. Do the stores that you described have a high turnover? Owners seem to sell stores every 6 months to a year in the community where this participant is working.
Yes, that was certainly one of the barriers that the local agency is implementing suggested. I mean, they do have, and the staff turnover. So one of the pieces that I didn't mention was nutrition education. They do a lot of nutrition education for the community, but it's really helpful to include the store employees in that as well. But they do have high turnover, and so it's kind of having to re-educate each time. So yeah, we do experience that.
Okay, great, thank you. And there's actually one more additional question for you, Pat. How are the results in an urban area where there is a grocery store such as Aldi or Walmart where healthier choices are less expensive? Corner stores tend to sell more processed food.
So one of the things that we're experiencing in Missouri is the rise of Dollar General in our rural communities, so very small rural communities, and there's just about one in every community. And so that was really an impetus for a lot of the retailers that are working with us in this program, is that they're fearful that their business was going to start losing money because customers were going to be shopping there. So I don't know that it's necessarily a urban versus rural issue, because we're seeing that in both places.
Okay,
and
thanks.
I think I'll just mention that with the convenience store offering more packaged foods, and so I think each community with each store that they work with has to identify what strategies are going to work the best. So because we do work with some rural grocery stores, they obviously have a wider selection of foods, and so sometimes it's more of the marketing piece that needs to be done in those communities, and education and building demand. Whereas if they're working with corner stores, then just considering how they might be able to make help the store owner identify some healthier products that they can sell.
Great, thank you. The next question is for Dr. Burrell. In Massachusetts, do you require your CACFP vendors to follow the Executive Order 509 guidelines? Dr. Burrell, you might be on mute.
I'm sorry, I had to take myself off of mute, excuse me. So can you repeat that question again?
Sure. In Massachusetts, do you require your CACFP vendors to follow the Executive Order 509 guidelines?
No, so not at this time. Those guidelines are specific to state agencies, and in the executive branch. So it's very particularly focused on those 9 agencies that I mentioned earlier. I will say that we have several pilots going on that relate to the SNAP programs, including under our federal grant 1422, exploring expanding healthy markets to not just be about food and beverages, but also tobacco and alcohol. We're just exploring that at this time, but we're also piloting with the concept of using SNAP. How can we help individuals incentivize to use SNAP for healthy choices? So they're things that we're piloting, and we hope to come back and speak to you about more later.
Hey, thank you so much. And just because we have a few minutes left, I want to check in with the operator to see if we had any calls come in over the phone line.
No questions at this time.
Okay, great. So with that, I think we're going to wrap up today's webinar, but I'm sorry if we didn't get to your questions. We can definitely follow up with the presenters and get answers to your questions for you. But thank you again for joining us today. As I mentioned earlier, you will be immediately directed to an evaluation at the conclusion of today's webinar. Please fill this out as it provides us with useful information for our future projects, and it also has questions related to the work you are doing to increase healthy eating in your state. I would like to thank the Office of Disease Prevention and Health Promotion for sponsoring this webinar, and I would also like to thank our speakers, Dr. Kelly Casaval, Dr. Monica Burrell, and Patricia Simmons. A recording of today's webinar will be available on our website within the next few days. The web address is on your screen now. Please check our newsletters and website for more information regarding the Dietary Guidelines issue brief that was briefly mentioned during the opening of today's webinar. If you have any follow-up questions, please feel free to reach out to me, Kristen Rego, at krego@asco.org. We hope that all of the listeners will use this webinar as a resource and will share the link with others once it is available. Thank you and enjoy the rest of your day.